Okay, we're going to get started. Hi, my name is Matt. I'm from Seattle. I am a 12-year papillary thyroid cancer survivor, and I'm joined virtually by Anjali, and I'll allow her to introduce herself, and then I will introduce the doctor.
Hi, everyone. I'm Anjali Kapoor Davis, an almost 20-year thyroid cancer patient. And uh, thank you all for joining us today online and in person.
And we're joined today by Dr. Whitney Goldner. Dr. Goldner is a professor of medicine and head of the Division of Endocrinology, Metabolism, and Diabetes at the University of Colorado Anschutz Medical Campus in Denver, Colorado. Prior to that, she was professor of medicine at the University of Nebraska Medical Center in Omaha, Nebraska, and the medical director of the Thyroid and Endocrine Tumor Program at UNMC Nebraska Medicine. Dr. Goldner has a clinical and research interest in thyroid nodules and thyroid cancer. She started the Thyroid Cancer Collaborative Registry at the University of Nebraska and was the principal investigator of the ICARE2, a multi-center bioinformatics and biospecimen registry for all types of cancer, which originated at the Fred and Pamela Buffett Cancer Center, University of Nebraska Medical Center Guidelines Committees. And with that, I welcome Dr. Goldner.
And we'll take questions. Thank you so much for the nice introduction, Matt. I was asked to talk today about systemic therapies in advanced radioactive iodine refractory, or what we often call non-avid, or sometimes you'll see it written as RAI-R, differentiated thyroid cancer. So just to be clear, this is not going to be medullary. It's more for differentiated thyroid cancer today. So systemic therapies for those. I don't really have any relevant disclosures for the talk today, but a few just disclosures are that I am a member of the ATA Thyroid Cancer Guideline Committee. I've also been a member of the NCCN Thyroid Cancer Guideline Committee when I was at Nebraska, and both of which put out recommendations for, topics like this. I have been involved in some research studies, both by Roche and Siemens. And I do some volunteer activity for the Endocrine Society. I'm the chair of the Clinical Affairs Core Committee and also the American Thyroid Association, currently the annual program committee co-chair. So none of those should impact my discussion today, but for full disclosure, wanted to mention those. So what I'm going to talk about today is just a little bit of overview of advanced thyroid cancer, just to set the stage. What are the types of systemic therapies? What are multi-kinase inhibitors? What's targeted therapy, immunotherapy, and then what are some of the new horizons? So I will tell you that, I've been practicing for about 20 years, and all of this has kind of exploded. Our knowledge has exploded and potential therapies have exploded in the last really 10 years or so. And so a lot of this that I'm going to be presenting is just a general overview of kind of how things came to be and when we talk about treatments, sometimes these all get lumped together, but people are talking about different things when they're talking about them. So this is really to kind of provide hopefully some clarity on what we're referring to when we talk about systemic therapies. So as far as treatment for advanced thyroid cancer goes, generally, people are going to need surgery first, where they're going to remove all the thyroid and then any lymph nodes involved. By definition, this is not low-risk thyroid cancers. So generally, that's why the whole thyroid and lymph nodes are removed. So we're not talking about all thyroid cancers, which is a whole nother topic, but generally what we can see, we remove. Then usually people will start with their first, what we call systemic treatment, meaning it can go anywhere in the body, and target thyroid cancer cells with radioactive iodine. Now, some people get one dose and some people will get multiple doses. That's really up to you and your treatment team and how well the cancer actually responded to that radioactive iodine. And so that's going to be different for each person, but that is usually our second step in treatment. If there was a good response to the last treatment and it is deemed that maybe there's been progression or maybe somebody needs a repeat treatment and the tumor takes it up, then that's when you might be able to get a second treatment. But if there was not a good response to that initial treatment, or there's no uptake in the tumor at the last time that somebody was treated, then we usually don't do any additional treatments with radioactive iodine. And that's when people kind of start referring to the term non-radioiodine avid or radioiodine resistant. So that's kind of the category that we're talking about today, is the people who have already gone through the initial treatments and their tumor is felt to be not responsive to radioactive iodine any longer. So progression after radioiodine therapy. Remember that treatment is individualized. There is no one right way to do this. So if you are actually, kind of talking with other friends and colleagues about kind of their journey, it may be that no two people are alike, and that's okay. It doesn't mean that one person had a wrong path and another one had the right path. It may just be how their tumors actually were behaving and what was most appropriate for them. In the current era, because we do base a lot of our treatment decisions on if there's any genetic or molecular changes on the tumor itself, genetic testing of that tumor is usually something that we consider if it's not already been done at this point in their therapy. And a lot of times people don't necessarily get that done earlier on in their therapy, but if they have advanced therapy and we're considering these systemic therapies, then genetic testing of that tumor is oftentimes something that we are starting to talk about doing now. Now, that can be done through a lot of different ways. Sometimes it's a test that's sent to your own institution because the pathologists do a panel of tests there. Sometimes it's sent out to a different company where they will run some tests and then send it back. And they oftentimes will do it off of your original tumor. So you don't always need a repeat biopsy to have this done. But if there's a particular spot that's growing fast and your doctors want sampling of that tumor just to know what's going on there, that's when you might need a biopsy of that spot. Now, in advanced thyroid cancer, if there is metastatic disease or residual disease, that doesn't always mean you have to get systemic therapy at that point. Let's say you've had the surgery and the radioactive iodine, and you know that there's disease there, but it's not really growing very fast or at all, then observation is something that we do. If it's not causing symptoms, not growing quickly, it's not near dangerous structures, and that might be very close follow-up with labs and imaging to determine the right time to consider treatment. And I know sometimes that sounds counterintuitive because you think, well, if I know it's there, then I want to go ahead and treat it right away. And if we had a treatment that we knew would make it melt away and cure it, we would, absolutely recommend that. But a lot of times when we're talking about these systemic therapies, we're talking about something that's going to stop it from growing or hopefully make it shrink a little, but we don't really have a therapy right now that guarantees that it goes away. And so because some of these treatments you can only do for a limited period of time before they develop resistance, we don't want to use them too early when things are not growing and then have it be resistant when the tumor starts to grow. And that's why oftentimes the timing is individualized as well as the right, what treatment is necessary. So there are other things other than systemic therapy also. So if there are some spots that would be better treated by, say, another type of radiation like external beam radiation, sometimes we consider that. And that's oftentimes if it's in a spot where, bones are oftentimes a spot that is well treated with radiation therapy, or if it's just one spot that's growing. Sometimes additional surgery is something that we consider if it's in a spot that would be okay to treat it like that. And sometimes there's other focused treatments based on their location and their symptoms, and those treatments kind of continue to emerge. Sometimes we do what we call radio frequency ablation, or we put a needle into something that's growing and try and kill that, as just another example. So again, we're not always jumping straight to systemic therapy if somebody has disease that is still present. We consider all of these options. But let's say that you feel like observation is not appropriate, or some of these other therapies are not appropriate. And if the areas are progressing, that's when we're talking about, okay, we need to consider doing something that is systemic, meaning it's going to affect the entire body. So it doesn't matter where the location is, whether it's in the neck or the lungs or the bones or somewhere else, it could potentially treat all of those spots together. And that's what I mean when I say systemic therapy. So this is absolutely a decision that you make with your physician and your healthcare team, because, and this is where multidisciplinary teams are really valuable, because no two groups look at it the same. And so a lot of times putting our heads together and trying to decide what the best decision is what we end up doing along with you as the patient. So everyone is different regarding the right time to start therapy. And so we have to kind of look at all of those factors when we decide the best approach. This was a good schematic, I thought, that Dr. Patoya and colleagues published. Now, I outlined the section we're talking about here today. Above the red box is more of the standard treatments. But if we think about, if you are a visual person, which I oftentimes am, it's better to look at this than look at words. If somebody's got radioiodine refractory disease, so they no longer respond to the radioactive iodine, then we decide what's the next best step. Well, as you all know, we give thyroid hormone and try and keep the TSH levels low. And then we consider, is it time for this systemic therapy? Now, if you look over here, they talk about what I just talked about. Was there failure for alternative treatments to systemic therapy? Is somebody symptomatic? Is it in a bad spot? Does it threaten vital structures, meaning it's near a blood vessel or in your bones where it's not a good spot where you could have fractures and things? And do you think that, so this acceptable performance status means, is somebody able to tolerate the treatment? Because these treatments aren't without their potential side effects. So are they well enough otherwise that we'd be okay to consider that? And if so, then we talk about doing the genetic testing. And so if there's no alterations found, there's no mutations on there, that's when we go in one direction, where it's more general and not driven by a mutation. But if they, sorry, I said it the opposite. If they find a genetic alteration, then it's driven by what their mutation is. But if there's no alteration, then that's when we consider the more general ones, or as I mentioned, sometimes depending on the pace of disease, we would do active surveillance or observation. All right, so this is a look at one of the pages of the NCCN guidelines for treatment of thyroid cancer. And so there's a lot of different guidelines out there. I would say the two that I tend to use the most are the American Thyroid Association guidelines and the NCCN guidelines. Now, NCCN guidelines are updated on a yearly basis. And so, and they are made, these guidelines are put together by all the member NCCN institutions and their experts while using the available literature out there. So you can see here, this is on the page that is for thyroid cancer. This one I picked for oncocytic, but it says it for all the different types of thyroid cancers. And so you can see here, they kind of outline what are the considering systemic therapies, and they list quite a few in here. Now I'm going to come back to this, but I'm going to individually address each one of these and tell you why we would pick one versus another. You can see here that lenvatinib is picked as kind of the first choice, but then sorafenib is next, but then this one is useful in certain circumstances. Well, that's because there might actually be situations where you would consider one of these before you might consider something else based on the details. And I will go through all of these details here that would help you make that decision. So the types. First, we talk about the TKIs, or the tyrosine kinase inhibitors, or sometimes they're called MKIs, multi-kinase inhibitors. And some of the ones that you would maybe recognize are sorafenib, lenvatinib. Oh, I spelled it wrong. That should have a, yeah, I did spell it right. And cabozantinib. So what these do is they actually have anti-angiogenic, so anti-blood vessel effects on the tumor. They inhibit the growth of these they inhibit some growth factor for the blood vessels, and they disrupt like the pathway that is feeding the cancer. Then there's another bucket that we consider called targeted therapy. And that's when we found a mutation that the tumor has that we maybe have a drug that can target that mutation. And then the last category that I always get asked about is cytotoxic chemotherapy, or what people think of as like the traditional chemotherapy, where you may have to go in and get an IV infusion every 3 to 4 weeks or so. Those are not generally the types of systemic therapy that we're talking about when we talk about systemic therapy for thyroid cancer. These have not been very effective over the years. And if we use them oftentimes in special circumstances, like if you're going to be getting radiation too, and that might help you be more sensitive to the radiation or something. So really, I'm going to be focusing more on the first 2 bullets about the types that we're talking about. Okay. So what are the molecular targets? Well, there's many of them that we have discovered in thyroid cancer. And so, as I mentioned, there's been kind of an explosion of knowledge over the last 10 to 15 years as far as what we know about a lot of these tumors. And so we have found that there are mutations that are very specific to certain thyroid cancers, and then there are drugs that can target those. So RET, or a fusion of RET with another mutation, are one of the mutations that we see in thyroid cancer. Now, this is also a mutation that's common in medullary, but I'm not going to talk about medullary today because this is more for the other differentiated type of thyroid cancer. So NTRK, or TRK, TRK, is another mutation that is relatively common in some thyroid cancers. BRAF is another mutation, and that's arguably our most common mutation that we see in these types of cancers. mTOR, I'm going to show you a picture that shows you where all these come up. This is another spot that we can target. That's not really a mutation. It more inhibits the spot in the pathway. ALK is another one. MEK is another one. And then we get to immunotherapy. So immunotherapy has gotten a lot of press for all cancers lately because it is a very good treatment for many solid tumors out there. It has not been used as extensively in thyroid cancer as it has in many other cancers, but I will talk about that briefly at the end also. So this, I think, is a great picture kind of showing you how many different spots we can actually target when we're thinking of treating thyroid cancer. This is not meant to memorize it or commit all these little spots to memory. It's more for the visual to show you that if this is a cell and we've got certain receptors that we're targeting, we've got drugs that target certain receptors, we've got certain mutations, RET I just talked about, we've got certain pathways here. This is that BRAF spot that we target. This is that mTOR we target. Here's that TRK. So again, this is more to just show you how many different spots we can target to keep this cancer cell from progressing. Okay, so we're first going to start with the TKIs or the MKIs. And basically, I've circled the ones that kind of fall in that category. I couldn't get my circle to exclude some of these, so pay more attention to this VEGF and some of these drugs in through here that fall into that multi-kinase category. So here was one of the original approvals. It's sorafenib. And this is one of the studies that basically showed that it was effective in people who had lymph node mets or metastatic radioiodine refractory differentiated thyroid cancer. And so I just want to point your attention here to red line is the sorafenib and the blue line is the placebo, meaning they got no drug. And if you look here, PFS means progression-free survival, meaning how long they were living without it increasing in growth at all. And this is time. And you can see that the sorafenib group did better. They had longer period of time that they went without it progressing than if you didn't treat them with anything. So that was good. That was one of the very first studies, but you can see this was 10 years ago. So then if you look at the bottom one, it's overall survival, and you see that it was hard to say that it was statistically different, but you can see visually here that the red group, which was sorafenib, seemed to do a little better. So this was kind of the start of when we started to learn about these drugs. Now, this is an article that kind of summarizes many of the sorafenib trials since then. And if you look at what I've circled here, PFS is progression-free survival. You can see with sorafenib, people in general were getting anywhere from about 8 to about 19 months of progression-free survival, meaning the tumor did not grow during that time. Now, this is important because in order to get on the drug, your tumor was progressing. So it means it halted it, and then maybe up to almost, 19 months, it was not necessarily progressing. And overall survival was not always measured, but you can see it was up to 32 months. So that's good. Now, these boxes over here tell you how well did they respond. And so PR means partial response, and SD means stable disease. So you can see that, roughly 50% of people had stable disease, but there were some people who had it even shrink in here. So that's good. Then we go on to lenvatinib. And that's another one of the multi-kinases. You can see same look here. The blue is lenvatinib, the gray is placebo, meaning no medication. And you can see overall, they did better if they were on lenvatinib, longer time before it progressed. About 65% of people actually responded, which was more than sorafenib. 4 of them completely responded, meaning the tumor went away, but most of them had what we call a partial response, which means they got smaller. And so that's really good. And so the response was a little better in lenvatinib versus sorafenib, although they both work, which is why lenvatinib on the NCCN guidelines is first. This is a summary of the lenvatinib trials, and you can see here, similarly, the progression-free survival was up to 18 months here, and this is overall survival. But you can see the percentage of people that had complete response or partial response or stable disease was a little higher. Now, I do want to point out that these come with some side effects. So high blood pressure is one of the most common ones, but you can also see fatigue, general weakness, lack of appetite. Sometimes it can cause you to leak some protein out of your kidneys. And so they're not without potential side effects, which is why we want to know how well people are feeling prior to getting on these medications. Okay, and then we move on to cabozantinib. You can see this was just a couple of years ago that this trial was published. And this one was slightly different than the other ones, where they had the refractory, they weren't responding to radioactive iodine anymore. They had to be previously treated with either lenvatinib or sorafenib, so the ones that had already been approved, and then they progressed on those therapies. And they gave people cabozantinib if they had progressed. And you can see 258 people were in it. And the orange is the cabozantinib, and the blue is the ones that didn't get the cabozantinib. And you can see they did much better if they got the cabozantinib for their progression-free survival. And so that was encouraging, because it meant that even if they had done okay on lenvatinib or sorafenib, but then started to progress, we had another treatment option where they could take that afterwards. So as I mentioned, there are some side effects of these multi-kinase inhibitors. One of the more common ones is this hand, foot, and skin reaction, where you get kind of a rash and peeling on your hands and feet. Diarrhea and nausea, so GI upset, high blood pressure, fatigue and decreased appetite, and weight loss. You can have some elevated urine protein levels, some hair loss, and headache. So these are things that you really need to be monitored for if you start on these medications. And it doesn't mean that you can't take them if you actually develop some of these, but a lot of times we've found that we may need to reduce the doses to get you to a point where you can tolerate it. And there are some people who can go down on the doses and do very well with it, and some people really have trouble tolerating the side effects. And so that's why we want to just make sure that we're monitoring those very closely. Okay, on to another category. It's TRK, T-R-K. And you can see here, there's 2 drugs in that category. Why do we care about these? Well, there are some NTRK fusions, 1 and 3, that are common in differentiated thyroid cancer. And they're actually fairly common in the pediatric population, so up to 25%. So this is something where you might measure the target, one of those targeted therapies. And if you found that they had an NTRK mutation, they might be eligible for one of these treatments. So this is larotrectinib, which is one of the medications that it's approved. This study shows you that they took data from 3 different trials, and they found that 29 patients had these TRK fusions. 64% who had taken the inhibitors had a partial response, 14% had stable disease, and 7 had a complete response, meaning it went away. Now, looking at these pictures, I think this is just a good visual where you can see below the line means these are all the different percentages response that people had. And this tells you the type of cancer that they had. And so papillary, poorly differentiated, follicular, anaplastic, all of those. So there were different types of tumors. Most of them were papillary, but you can see here that they all seem to have some degree of response here. Now you can see in here, if it's above the line, they didn't respond. So not everybody does. And these are more of the advanced anaplastic, poorly differentiated patients here. This is just another way of showing how much of a response they had and the timing of it. And so you can see the start of their partial response is in yellow here, and then start of the complete response. So the longer they went here, and then how well people's progression went. So what are the side effects of treatment with these TRK inhibitors? Well, you can have myalgias, which means muscle aches, fatigue, nausea, constipation. So they are also not without their side effects, although some people feel like they're better tolerated than the other ones I just talked about, the multi-kinase inhibitors. So next we'll talk about the RET inhibitors. So you can see here I've circled where the RET is, and there's 2 drugs in this category, selpercatinib and pralsetinib. So these are kinase inhibitors that selectively target RET. Now, these can also be used in medullary. I'm not going to talk about medullary today, but in differentiated thyroid cancer, there can be a RET PTC rearrangement. So basically, there's a mutation that involves RET in papillary or differentiated thyroid cancer that makes it such that you can use this drug for both differentiated thyroid cancer or medullary that have these RET problems. I apologize, that's a little fuzzy. But this is one of the trials where we learned that selpercatinib was effective against these RET fusion differentiated thyroid cancers. We had already known that it was good for medullary, but they basically looked at 26 people who had these RET fusions and found that 62% had a partial response and 35% had stable disease. And as I showed you before, below the line shows you how much they had a reduction. Here's another study where they enrolled both medullary and RET fusion differentiated thyroid cancer, and similarly found that in people who were treated with, they included people who'd been treated with other treatments like the multi-kinase inhibitor. They had multiple types of thyroid cancers, and 79% had an objective response. So this is important because they already got treated with one, like lenvatinib or sorafenib, and then they could go on to have this because it was targeting their mutation, and and they had a good response. At 1 year, 71% had ongoing responses and 64% had not had any progression. Here's on pralsetinib, another one in that class for advanced metastatic RET-altered thyroid cancer, the ARROW trial. And what they found is an 89% response rate. Now, you can have side effects with these also: constipation, high blood pressure, fatigue, muscle aches, diarrhea, and it can cause some lab abnormalities like lower white blood cell counts, hemoglobin, platelets, calcium and sodium levels, and then increased liver function tests. So all of these, you need to be monitored closely for a lot of these side effects, and treatment needs to be adjusted if you're not tolerating it. Okay, what about BRAF? So as I mentioned, BRAF is probably our most common mutation. It depends on what articles you look at, how common it is, but roughly we estimate that it probably affects 60% of all cancers, not just advanced ones. Usually if the medication, the target of a BRAF inhibitor is given, they also give it with a MEK inhibitor. And you can see these two are right next to each other on this cascade of cancer of the mechanism. Now, dabrafenib and vemurafenib are the two BRAF inhibitors. These are your two MEK inhibitors. This is just a table to show you how many trials have been working on what's the right combination and in what population do we use these types of medications. Again, not meant to be for memorization here, but to show you that they've been using these medications that target that BRAF mutation to see the best optimal way to treat people. Here's one of the earlier studies that showed that dabrafenib was actually a beneficial medication for people who had this BRAF mutation. And again, below the line is good. Not everybody responded, but some did. This is a more recent one, the RAI-R trial, that looks at both a BRAF and a MEK inhibitor. And this trial basically looked at lots of tumors that had BRAF V600E mutations, 21 different types. And it was a prospective study putting people on these inhibitors to see, did it impact their outcomes? And you can see here that there's lots of people who did well, who had thyroid cancer. Now, this one specifically is anaplastic, and they do seem to do well with BRAF V600E mutations with anaplastic. It has also been studied in papillaries, but our most robust responses have been kind of in the anaplastic or less differentiated groups. So what about immunotherapy? As I mentioned, immunotherapy is something that gets talked about for a lot of the solid tumors that are not thyroid cancer, and is oftentimes the first thing that people will consider. But it's not been something that has been as, I guess, successful in thyroid cancer. That doesn't mean there aren't studies ongoing and that they haven't had some results, but I think that there's going to be more to come in this space in future years. This is just one study published last year, the Keynote, where basically they looked at how well did it work and the safety of pembrolizumab, which is one of the immunotherapies, and looked to see in many different tumor types, similar to the last study I talked about, how well they did. They also looked at the number of people, if they responded, if they had a certain kind of expression of some of these immunotherapy markers on the tumor or not. And you can see here, if we look at the ones that responded, those are below the line, it didn't seem to matter whether they had this expression of that immunotherapy marker or not. It was kind of a mix of green and magenta there. And then these people really didn't respond. All the ones that are above the line didn't respond. So you can see it's not nearly as impressive as the people who've taken those other medications. If you look out here for duration of response, at 6 months, the ones who responded, it was about 71%, but all the way to 24 months, maybe only 19%. So I think more to come in this arena, but there are lots of trials looking at this. And so it's something that is an important thing to study, especially because we don't know, is it something that will be with these other medications or by itself or with other drugs that we have not discovered yet. But this is something that is a hot topic in other cancers, which is why I bring it up. Okay, so let's go back to the NCCN guidelines. So we talked about lenvatinib and sorafenib and cabozantinib. So those are all the multi-kinase inhibitors. You can see here, this one is useful in certain circumstances. Cabozantinib is because the study was after they had progression with one or the other of these two, lenvatinib or sorafenib, then you can use cabozantinib. But it really hasn't looked at as the first line. Larotrectinib or entrectinib is for the people who have these NTRK mutations. Selpercatinib or pralsetinib is for people who have these RET mutations or rearrangements. Pembrolizumab, so that's the immunotherapy ones, are for people who've had some of the markers that may predict that they would respond, but it says also who've progressed following prior treatment with no satisfactory alternative options. And the reason is because there's not as much data that these are as effective. You can see here, dabrafenib and trametinib for people who got the BRAF mutation. And then other therapies are available and can be considered for progression or symptomatic disease if clinical trials or other systemic therapies are not available. So I want to bring up that we haven't discovered everything that there is to discover in this realm. There might be more that come out. And so it's really important to continue to participate in clinical trials if these are not great options for you on an individual basis. So in summary, there has been a lot of progress in the treatment of advanced thyroid cancer, especially over the last 10 years. Therapy needs to be individualized with your provider. No two people are alike, and it may be that you have a different journey than somebody else that you've spoken with, but it doesn't mean that either one is wrong. It may just be that that's individualized to your cancer. Not all metastatic disease needs to be treated right away. Observation and determining the right treatment, time, and the right regimen is important. And so sometimes that can be hard to know when the right time is, and that's why it's something that you make as a decision with your provider. If it does need to be treated, we have multiple options. And again, we try and personalize the treatment for each person. If there's a mutation, there might be something that we can direct the therapy towards, or we might want a more general treatment. And so that's something that has to be taken into consideration. We also know that if there is resistance that develops to some of these regimens, then switching to a different regimen does seem to be an acceptable alternative and effective for certain people. So that's it's not like there's only one treatment for each person. And then always consider clinical trials, because that's where we're going to learn more and be able to make headway in this space. And clinical trials is what allowed us to advance as much as we did in the last 10 years. And so that will potentially help us learn more and more about optimal treatments. And we would love to ultimately find something that is curative for metastatic cancer. So what's on the horizon? And I guess specifically, what did I not speak about today? Because one, we only have a limited amount of time, and two, we don't necessarily have as much data on some of these areas. Well, there's something called redifferentiation therapy. So when I was talking about the treatment for systemic therapies for these other scenarios, it's for the people who were no longer concentrating iodine in their tumors. Well, there's something called redifferentiation therapy, meaning we give you a medication that will allow your tumor to take that back up again. So sometimes the medications that I talked about today, some of those can be used in preparation for another dose of radioactive iodine for what we call redifferentiation therapy. There are ongoing studies for this, and there's been a lot of reports over the years. It is not, I would say, standard of care routinely at this point. However, there are people who are trying it when there are no other options, and certainly studies are ongoing. So more to come in that arena. Neoadjuvant therapy. So what I mean by that is you get the systemic therapy before you have surgery. So not the reverse, like I already talked about, where it's surgery, then radioactive iodine, then systemic therapy. This is in people who may present with metastatic disease or very aggressive disease right up front when you first meet somebody. And so this is being studied also in different types of thyroid cancer. And so in some people, what's being studied is it better to give somebody systemic therapy and try and shrink it a little bit so that then surgery is maybe a little more effective or safer? So more to come in that realm too, but that is something that other cancers do that, and this is something that's emerging in thyroid cancer. Also, second and third line therapies. I showed you a little bit of the data behind, if you progress on one, then which one do you pick next? But I think there's more to learn in that area about what's the right order in which you do these systemic therapies. And then there's new discoveries. There are things that we maybe have not even uncovered yet in treatment. And like I said, in the last 10 years, there's been an explosion of knowledge. And I think that in the next 10 years, there will be even more. So I think that continuing to have research, participate in clinical trials, get basic and clinical research studies done, that's all important for us to increase our learning. So with that, I'd be happy to take questions from the audience. And thank you for inviting me to participate in today's session.
Thank you so much, Dr. Goldner. We appreciate your time and your very thorough presentation. A patient that has PDTC, TERT, RAS, okay, it's a pretty lengthy number of different mutations, and others for 14 plus years, has had thyroidectomy, RAI resistant on various TKIs, and they're asking if they're looking at immunotherapy trials. They've unfortunately not been able to participate in that. They've been rejected for that because of ulcerative colitis. But that's been in remission for 10, 15 years. Will there ever be an immunotherapy for a person like that, given the autoimmune disease of ulcerative colitis?
Yeah, that's a really good question. And you bring up a good point about immunotherapy. So immunotherapy, just so we're all on the same page, is basically a treatment where the immune system will attack the cancer, which when it's effective can be really effective. But the problem is because it's the immune system attacking the tumor, it sometimes can attack other organs that are not cancer. And so that can make autoimmune conditions flare for some people. And so the question about, say you have an autoimmune condition, that is something that prevented being in a trial. Are they ever going to be able to do that where people who have these autoimmune conditions can be part of the trial? That's a really good question. And so I would bet that if immunotherapy looks like it has promise, and we want to know exactly which populations it's most appropriate for, those studies will potentially expand in the future to include people that have autoimmune conditions. But I think it's so early in the knowledge of these drugs that they have to take people who don't have them first to figure out, you don't want to make an underlying condition worse. So it's always hard when there's restriction criteria for that. Now that's a question I think for you and your treatment team to have. If it's been in remission, what are the pros and cons, and, you know, are there other treatment options? But that's probably why it's not been part of the clinical trials. So I'm sorry.
Thank you.
Mhm.
We have another question asking, can you stop the TKI for a period or do you have to take it continuously?
Yeah, that's a good question. So you can stop it. We oftentimes, well, we do it for a couple of different reasons. Sometimes if people have side effects and they are significant enough, an alternative to just lowering the dose, like if we want somebody to just kind of feel better and then start at a lower dose, that would be a time to stop it and then maybe start lower. Another situation would be, say, if especially the ones that inhibit your blood vessel formation, kind of the multi-kinase inhibitors, oftentimes we stop those for surgeries. And it's because it might impair wound healing. So it doesn't necessarily have to be just thyroid or thyroid cancer surgery, any other surgery. They may want you to stop that for a period of time until you've healed and then start it again. So yes, they can be stopped. Now, as far as treatment holidays, I think that there's not a lot that's known around that necessarily. And so by taking it for a little bit, stopping it, restarting, I think we need to learn more in that realm before saying there's a perfect way to do it.
Thank you for that.
Mm-hmm.
We have one more.
Mm-hmm.
If a patient has a recurrent Sept or RAI, does that mean that cancer is RAI resistant?
Yeah, that's a good question. So, you know, we debate, you guys are a good audience. These are hard questions. We debate this a lot about what is the actual definition of RAI resistance. And there's not great consensus. There are some guidelines out there. But we actually have a task force of lots of different types of physicians, nuclear medicine, endocrinologists, oncologists, and things, trying to figure out what is the best definition for that, because it's kind of different for everybody. So I would say this, let's say somebody got treated with radioactive iodine and progressed pretty quickly after that treatment, then I would be more suspicious of it not being avid if you had just been treated and it continued to grow, than if you were treated, say, 10 years ago and then developed a recurrence. Then I wouldn't necessarily say that you absolutely are radioiodine refractory, unless I look back at that first treatment and I see that you didn't have any uptake. You had no radioactive iodine uptake on your post-treatment scan. So that tells me that I didn't see it go anywhere when we did the treatment. That's where I might wonder if you were not resistant, or I mean, if you were resistant to it.
Thank you. So our next question is a patient that has Hürthle cell found in 2014, metastatic in 2016, started Lenvima in 2019. I've had to reduce the dose and take 1 week breaks, progression in 2023, added Keytruda this year, and still having progression. Stop Keytruda. What do you think might be the next steps?
Yeah, so that's a tough one too. So I think that, so just to recap, so Hürthle or oncocytic, they've changed the name recently. So you might see both of those terms. They mean the same thing. They just changed the terms. And so that, so it sounds like the person was radioactive iodine resistant, went on Lenvima, which is lenvatinib, which is the first line of therapy, then had Keytruda, which is immunotherapy. That is the pembrolizumab. So had that on top, but still having progression. Then I think that the question is, what are the other potential treatment options? And so this gets into that very bottom recommendation that was on the NCCN guidelines is, okay, let's think of other things. So if there are some spots that are specifically growing, but not all of them are, you know, would they be amenable to treating those individually? Like if it's a couple spots, could they be treated with radiation or something like that? If it's all of them progressing, then you're thinking of what are the options for another systemic therapy? And in that situation, the one that we talked about that has more recently come out is like cabozantinib, where they have progressed on the Lenvima and could consider that. Now, again, I don't want to be the one dictating what the next step is. Your doctor will probably be the best informed about your case, but kind of thinking through some of what are these other treatment options if there are not mutations to drive what the next step is.
Thank you so much.
Mhm.
Okay. Are there situations where you're deemed RAI resistant, but given RAI anyway, prior to starting TKIs and saw uptake? I think they're talking about redifferentiation, but
Okay, and saw uptake, they say. Yeah, so I think Angela, you might, I think I was thinking the same thing, that maybe this was a situation of doing redifferentiation therapy, like I talked about, where you might take something where then it makes you more likely to take up radioactive iodine. If it was not that scenario, like it, and maybe let's say it's a scenario where your doctors are not sure if you're radioiodine resistant, and they can't make a decision based on your past treatments and things. They might try and give you a dose just to see if you responded. And if you did not, then they could call you radioiodine resistant and then consider systemic therapy if you progressed. I'm not sure which one of those it is, but hopefully I've covered either scenario.
thank you. Okay. I'm going to try and pronounce these names. Have a caregiver that's writing in about their spouse that has been on pazopanib.
Pazopanib, yeah, okay.
Okay,
Yep.
I was way off.
Yeah.
Pazopanib for 2 years, and that works well with little side effects for Hurthle cell cancer that has metastasized to lungs and is not covered by insurance. But the drug company has been giving it free and is going to stop the free program. What would be some good alternatives?
Oh, that's a really hard one. So yeah, pazopanib actually falls into those multi-kinase inhibitors. And it was something that there is some evidence that people do well on it. I've had some patients who've done well on it, but it was not one I covered because it's not been specifically studied like the other ones, because it was used before they even kind of were in these trials. So I'm glad to hear that it's been working well. I guess I would first talk to your doctor about whether there's an alternate way that you can get it paid for, since it has been working so well. And because, if it's been working well, you don't want to have to stop that. And sometimes there are ways that the social workers and things can help out at hospitals to help with that. If it's absolutely not going to be possible, then potentially switching to another one in that same category of the MKIs. But again, that is a decision that I think you and your doctors want to talk through and talk about the pros and cons of each one of those.
Thank you for that. I believe there are some patient assistant programs as well. And that might be something to look into. How do I decide if I should start TKI when I'm totally asymptomatic? Those scans are showing accelerating growth.
Yeah, that's, I would say, one of the hardest questions. And I feel like when I have this conversation with people, it really is a shared decision, between me and the patient, and actually the medical oncologist too. So as background, I'm an endocrinologist. And even though I do this on a regular basis, when it's time to put somebody on a systemic therapy, I oftentimes partner with my medical oncology colleagues, and the two of us are kind of co-treating people for it, partly because we look at things from a slightly different perspective, and we monitor, we both are monitoring. So if I've been seeing somebody for a long time and they are starting to progress and we feel like, okay, it's time to consider doing systemic therapy. If they have not already met the medical oncologist, then I usually have them meet my medical oncologist colleagues, because we might each have a slightly different take on it. So, and then, you know, if we're both in agreement, I think that that's something that is comforting for the patient. But if we have differing opinions, then they can hear both sides of it. So, for me, I guess when we usually talk about when's the right time, I would say if you're asymptomatic, then looking at only growth is kind of the hardest thing. So if we think back to what got people into the trials, that was kind of the clear resist criteria, which means it had to have grown by a centimeter, or it had to be, you know, having like within a certain period of time, within 6 to 12 months. You can't, I guess I wouldn't say if it's grown by that amount in 10 years that that's necessarily fast growth. And so that's kind of what I fall back on. But I also think about patient preference too, and the amount of, you know, stress and things that it's causing, because we weigh the pros and cons of the side effects too. And you're going to find people who are, some are a little more aggressive up front and some are a little less aggressive. I don't know that there's a right or wrong answer. It just has to be what's best for you.
It's a common question in the RAI resistant group. We have like, when do we start?
Yeah.
I've had that same question myself.
Yeah.
Been on wait and
It's a
watch
really hard decision. It's a really hard decision.
Yeah.
And I feel like that's why I like I like to start talking about it early and have them meet the medical oncologist early, so that you don't look back and think, oh my gosh, I just rushed into this, that you have plenty of time to, you know, kind of think through it and make a informed decision.
Understandable. Absolutely. Let's see if we can get one more in before we have to wrap. A PDTC patient who's been on many TKIs in the past 14 plus years, but meds are in inaccessible place, many lung meds. How important or valuable would it be to retest for genetic mutations on the new inaccessible meds? Original mutations done at least 10 years ago at Memorial Sloan Kettering and the IMPACT study.
Yeah, that's a good question. So I'm not sure I know what you mean by inaccessible. If it's inaccessible, it may be hard to biopsy too. So I wouldn't want somebody to have more problems from having a biopsy in a bad spot and then having, you know, a side effect from that. But this is something that we talk about a lot now, is when do you repeat a biopsy and reanalyze? And so I will say that I have had some people where, like, if their genetic testing was done a long time ago, you know, we've discovered a lot in the last 10 years. And so if they're progressing and we've kind of exhausted all the other options, I sometimes will rebiopsy a growing lesion, not just retest their original tumor, but I might biopsy something that clearly seems to be progressing and then see if there's anything new. A lot of times there's not anything new, but if it wasn't tested before for some of these most common mutations, I think that can be beneficial. And then it might make them eligible for one of those newer targeted therapies that weren't available before.
Good to know. Yes, they were talking about inaccessible in the lungs. That's what, yeah.
Okay.
Same problem. Too small or too many and all of that.
Yeah, and that's hard when it's too small, because you're right. If you just get normal lung tissue right next to it, that doesn't help you so much, you know?
Right. Yeah, that's my case. If my recurrence appeared on ultrasound 2.5 years after RAI, would you consider my cancer to be RAI resistant?
Not necessarily. You know, I think that there's a big debate about recurrence versus residual. Sometimes people can have microscopic in there that just took a long time to grow, and maybe that's residual, you know, or did it truly go away and then something came back? But I don't think that's an automatic categorization. I think you have to kind of look at the whole picture and how quickly it grew and what it looks like and stuff. But that and sometimes those recurrences don't need more radioactive iodine after them. They can just be treated surgically. So
excellent. Okay. And another question, are newly emerging lesions a possible trigger for systemic treatment?
Depends on where they're at. So if they're in a place that is surgically resectable and they're the only ones growing, then maybe systemic therapy is not necessarily what you would jump to first. Like I said, sometimes there's a role for just targeted therapy, not systemic, but like external beam, if it's just a one spot growing or something. I've had cases before where like they might have widely metastatic disease that hasn't changed at all, but then just one little spot seems to be growing. Rather than go on systemic therapy, then maybe we just spot treat that one spot that's growing. So it kind of depends on the situation.
So the patient has spinal hemangio. Oh, Lord have mercy.
Yeah, hemangiomas. I can see that one here too. Can they still take the drug that stops? That's a good question. I guess you would have to have the radiologist take a look at it and talk to your oncologist or endocrinologist and see, what's the size and things like that. But that should be something that is considered when they're making that decision.
After 20 years of dealing with thyroid cancer, you think I'd be able to pronounce all these things?
No, they're hard. They're really hard.
Thank you for that. Okay. Let's see. We've got follicular with bone metastasis to 5 spots. RAI had uptake in whole body scan, and TG went from 3,600 down to 200 over 9 months. And then the PET at 12 months out of RAI showed growth on 2 spots and was diagnosed RAI refractory. TG has gone up to 400. I'm told I'm partial resistant, the question mark. No pain in last year, going to soon to discuss next steps. Am I a candidate for redifferentiation, or should I consider radiation on the growing areas?
Yeah, those are good questions. I think, as I mentioned, redifferentiation is oftentimes something that's done in the setting of a trial, because it's not standard necessarily yet. And so you could certainly ask about that and see if they've got a trial or if they're doing that. I think sometimes bone lesions, we don't treat with radiation unless they are in a bad spot, or if they're causing pain, or if they're, we're really worried about them fracturing between them. So not every bone spot always needs external beam right away. So we do recommend that you be on a bone stabilizer like a bisphosphonate or denosumab. That's like the osteoporosis medications, because those help stabilize those spots, but it's not really as a cancer treatment. Oh, good. This person says I'm on Zometa. Good. So I think that those are good questions for them, and see if they actually have a trial. But depending on the size, they may not necessarily recommend radiation if you're feeling perfectly fine. You're welcome.
Excellent. Well, thank you so much. It looks to be the last of our questions. I really appreciate you taking the extra time to get through those and your thorough research.
Absolutely. I'm happy to be here, and thank you for the invitation. You guys all have a great rest of the meeting and a great rest of the day.